All right, welcome everybody. This is session 2 of our health economics class. And what I'm going to do today very briefly is give some context around chapter 2 of the book. So chapter 2 goes into a little bit about the theory of demand, and it talks about these economic and health policy experiments that are done. So I'm not going to go too far into that, but I do want to give some context. So what we're going to do today is I'll be using my blackboard here. And again, there's my chicken scratch, but I'm going to give a brief overview of kind of the process of science, the scientific process, and then I'm going to apply it to demand in healthcare, and then go into setting up economic experiments. And all this kind of goes together pretty quickly. Now, the reason I want to kind of detail this process of science is we are seeing it everywhere during the COVID crisis. People are thinking that they understand what scientists are saying about masks or various treatments or social distancing. We have some scientists saying some things and doctors saying other things. How do we get through? How do we consume this information in a healthy manner? Well, understanding the process of science helps. So let's go into that first. And I have a video up on the web already, but so I'll give just a brief breakdown of this. The first step of understanding some social policy or some health policy or some medical intervention starts off with, what do we already know about the phenomenon we're talking about? So, using very broadly the term theory, what have previous thinkers said about this? And again, let me go through this big level scientific method process stuff, and then we will hone it down into demand for healthcare. So you take these big level ideas, and from these big level ideas, if you have succinct operationalized theory, then why you want theory is to make predictions about the world, okay? Make a prediction about a relationship between two things, okay? So the next box here is either predictions or hypotheses. You make a hypothesis about something going on in the world. All right. Now you don't want to leave it there. Okay. That's if you just go from theory to hypotheses, you're basically just armchair quarterbacking. All right. You haven't said anything. You don't know if it actually works. The next part of step in science is you really need to do empirical studies. Okay, you need to apply your theory and test your hypotheses in social science and public health on real people, okay? In other sciences, you're doing it on cells or atoms or molecules or shooting rockets into the air or whatever you're doing in the hard sciences. In social sciences and where your observation is people, you need to do studies related to the behaviors and the choices of people. And that's what we'll talk about later. From your empirical studies, you find out, was my hypothesis correct or incorrect? So that allows us to either verify or adjust our hypothesis, okay, and our theory. So this is a very, very simplified example of the scientific process. I have links on the website to much more uh, complex ones, and how there's a lot of creativity and a lot of social science is more of an art than a science sometimes. And y'all are doing your studies to understand that more, and then if you go to grad school, you even better will understand that. So here's the thing. What's been happening during COVID is there will be one study done, okay? One study that has some theory, has a hypothesis, one empirical study, and that's it. And then people are going wild and sharing that study and trying to, news outlets are saying we know something from just one study. But that is not the process of science. The final step in this thing is that other researchers, they may tweak the theory. They may have different hypotheses. They may apply other theory to this question, this research idea that you're looking at. They may do the empirical studies differently with more people, okay? And then they can verify and adjust what's going on. This is done not by just one researcher, but the community of researchers. Science is a community-driven process, not one person in their lab. This final step is perhaps the most important, but it's the step of replication. Other people with other views, a diversity of views, need to be doing these studies. So, for example, repeated studies that are double-blinded, which we'll talk about on hydrochloroquine, are finding that it's not helpful for COVID. In fact, it may be more harmful, bring in more potential harm than more potential benefits. And it's only through the process of replication, not just one person's view, but many people sharpening each other's views. That's how we're learning about this. So let me apply this to what we're talking about in health economics, specifically chapter 2. The theory that we are using is the theory of demand. Okay? So let's scoot over here and highlight a few pieces about demand. Demand theory makes a couple of hypotheses. Namely, you all had principles of micro. The main aspect about demand theory is if your price goes down from, say, $10 to $5, let's say at $10, people are consuming or utilizing, say, I don't know, 10 units. We could well, I'll do it general, but then we can apply it to medical treatments or something like that. Demand theory basically says if you start off at point A here, oops, that's not a very good A. I'll call it point 1 here. Point 1 here, at $10, people are consuming 10 units. Let's say the price goes down at point to $5. Demand theory predicts that more people will consume this thing. So maybe it goes up to 15 units being consumed. So in sum, the prediction of demand theory is that demand curves slope down. As prices fall, the quantity of something being demanded rises. Okay? So applying economics to health, which we want to do here, is we make our first hypothesis is even if we're talking about healthcare and things like that, if the price falls for something, the utilization or the quantity is going to go up. So typically in health, we don't say you consume, I mean, economists say you consume health treatments, but that's kind of a weird way of saying it. You typically talk about the utilization of a treatment. Okay, so but even so, as price goes down, utilization will go up. Okay, so that's the first hypothesis. A second aspect of demand theory relates to kind of the response, the quantity response. How big is a quantity response if price goes down? Okay, so I'm going to do two different demand curves and examples here. The first demand curve is going to look something like this. Let's say that at point 1, let's say there's 15 people utilizing a service. And if the price drops to 5, only maybe one more person, this goes up to 16. Only one more person utilizes that service. What's going on here? Well, let me tell you. For some services, it does not matter what the price is. If the price is $5, $10, $20. If you need that service, you're going to use it. So the example I like to talk about is this, my son was, we were in Texas visiting my family and taking my son, who was about 6 at the time, to go get a ice cream. And so he was super excited, jumped out of the car, closed the car door, and shut his thumb in the door. And that was scary. You know, he did it pretty hard too. I couldn't get the door open for a second. So I'm in Amarillo, Texas. I haven't lived there for many years, so I don't know, urgent care, where all these places are. So I look on my phone and I find that there's several of these urgent care or MedExpress type places that can deal with, not crazy emergencies, but, something that needs to be taken care of urgently. And so what do? Did I call around looking for the lowest price and going to the place with the lowest price? No, of course I didn't do that, right? Because I'm a loving father. I took my son to the closest place regardless of the price. So most people in that situation, it doesn't matter if the price is $10 or $100. They're not going to say, that's too expensive. Rub some dirt on that thumb, boy. I didn't do that. No, it didn't matter what it was going to cost. I wanted him to be okay, So in these instances, the demand curve looks something like this, the very vertical curve, to where utilization is not dependent on price. There is another need, an immediate need for that, okay? So in instances like this, where there's immediate need, and then demand is unrelated, it's unrelated, that's what that says, to price, relatively, we could say that this will be an elastic good or service. It's an elastic good or service. So examples like this are going to be things like ER services, emergency services, pediatric services. People don't mess around with their kids. If your kid's sick, you take them in. So these are types of health services that are going to be more elastic, okay? So a second hypothesis then is that certain services, oh, I'm sorry, golly, I messed this up. Inelastic, I'm sorry. This is inelastic. I'm talking about inelastic services. All right. Inelastic services. Go back, change your notes. ER services, pediatric services are inelastic. So inelastic represents that lack of price shopping, that lack of time to look at different things to purchase. It's immediate need. Demand is really unrelated to price. So what's it related to? This number here will be some level in the population that requires ER services in a given day. You know, things that are also related to life or death. So I would imagine something like certain types of cancer treatments. For late stage cancer, someone may do that at any price, wish to engage in that treatment. Okay, those are inelastic goods. So another hypothesis coming from this demand theory is that these types of things will be inelastic. Now you measure this with data on price and quantity. Okay, so we'll do that in a second. The last thing I want to do is not everything's inelastic. Some things are more elastic. Okay, so again, we have price, we have quantity. If the price goes down from 10 to 5, you may see a lot of people engage in that service or start to consume that service and move from 1 to 2 this way. Okay, so maybe $10, not many people were utilizing this service. Let's say it's only 5, but at $5, utilization goes up to 20 people. Okay, this indicates that this is not a service. It could be a medical service or a treatment that doesn't have that immediate need. But when the price goes down a little bit, people use it more. Okay, so one example of this that I have used before is LASIK surgery. Okay, this is something that I paid out of pocket. My insurance didn't do it, didn't take care of it. I looked across different doctors. I wanted to find a high quality doctor that wasn't going to break my budget. I had time to shop around. Okay. More generally, we would call these certain types of elective surgeries or elective treatments. They're not immediate. Okay. I don't have to have it done now. And I could hopefully look around for that. So elective treatments, we would expect to be relatively more elastic than, say, ER treatments. Okay, so that's the third hypothesis. So the first hypothesis is that we'll have a downward sloping demand curve. The second hypothesis is that we can predict or we can hypothesize about certain services that will be inelastic, such as ER, pediatric. And then third, we can predict that certain types of elective surgeries will be more elastic. Okay, so what do we do about this stuff? All right, so that's the review of demand theory. Now we go to the next step. We've done our theory, we put it together hypotheses. Now we have to do some empirical studies. Okay, so we want to set up research that allows us to test if the price falls, can we must measure quantities, which is healthcare utilization. Okay, so we have to be able to, in our research, who are we doing research on? We're doing research on people. So people, that are getting a lot of different treatments. We want to trigger in research a price drop. So whatever they're paying to go to the doctor or go to the hospital, at one point, we want to trigger a price drop and see how that affects their consumption and utilization of these services. Okay? So let me make another aside here. Oh, I need to get a new Blackboard area. Okay. So give me 1 second. I'm going to bring up a new window. Okay. So how do economists and scientists more generally turn these ideas into empirical research? Well, the gold standard for these is called a randomized control trial. Okay. Oops. I can't make a straight line. Okay. Randomized controlled trial. Now, a lot of this this methodology comes from hard sciences and comes from testing new pharmaceuticals. Okay, so that's kind of the background, but economists use this as well, and health policy people use these this setup so we can isolate one effect. Okay, so that's the idea. The idea is lots of things affect, in this instant, healthcare utilization. Our theory, remember, our theory posits this relationship. The price of healthcare is related to the quantity or the utilization. But in reality, lots of other things also affect utilization. How sick people are, the environment, income, etc. Okay, we have lots of other things doing this. Why you do the randomized control trial is you want to isolate the effect of one variable. Okay, and here in our example, we want to isolate the impact of price going down. Okay, so here's how we do it. In the gold standard, in the best case scenario, what you do is you take a population of people. I'm gonna make a, yeah. This is our population. Okay, this population should be fairly diverse by things that we think are important. So age is going to affect, one of these things is going to be age, income, etc. So there should be a range of ages here. There should be a range of incomes. Okay, so the population is scattered all through here, right? You just have a big group. So what we want to do is we want to randomly separate this population into two groups, okay? We want to randomly separate this population into two groups. So some people come up here, some people come down there. This should be random selection. Okay, so we're not splitting up half the people by age, old and young. Then we can't, there are two different groups. There's going to be selection bias. We can't do it by gender or race or high or low income. We want to randomly select these, okay? And what that gives us is we're going to now have two groups. On the top, we'll have the treatment group. And on the bottom, we'll have the control or comparison group. Control or comparison. Okay? And typically you have even more groups. You would have a placebo group along with a control. So for example, if I were testing a medicine, a new pharmaceutical, I would have a control. I'm looking to see, let's say if this pharmaceutical helps with a respiratory illness or something like that. Let's say I'm going to test the effects of hydrochloroquine on COVID symptoms. Well, you have to have a group that's your baseline. Okay, the baseline group would be getting no additional medical pharmaceutical treatment, right? So let's say everybody in this population is going to get, you know, baseline care, okay? Respirators, they're in a hospital, they're getting some baseline care. The comparison group gets nothing additional or special, okay? So that would be the comparison group. And you'd want to see, you want to look at time. So I'm splitting this up before. So I'm going to split this into a pre-treatment and a post-treatment. So one example is, you know, these COVID patients in the control group, they're going to get nothing pre and then nothing afterwards. The second group would be a placebo group, and they would get something like a sugar pill. So they're getting the same baseline care, but in the pre-state, but at some point in time, they start getting a sugar pill, and we see if a sugar pill helps them. And then the third group would be the treatment group. They start off not getting anything, but at some point in time, they get the hydrochloroquine. And then that would give you three groups, and you could tell the difference between hydrochloroquine and the sugar pill. Is there any difference there? Are the outcomes better? And then the sugar pill and the control group. Is there any difference there? Okay, so these are best case randomized controlled studies. And from what I understand of the hydrochloroquine literature, we're not finding that HQL has benefits, okay, compared to doing nothing. You know, again, one of the things that also help with utilization or outcomes is just time. You know, most people who get COVID get better with time. So if I'm giving you a sugar pill, and I may think naively, oh, that sugar pill helps. But really what's helping is time. People get over it. Their body fights it off, whether I give you a sugar pill or not, whether I give you hydrochloroquine or not. Okay. Anyways, back to our example now. We want to look at these outcomes for the treatment in the control group, price and quantity. Okay. So here we want to see what is the utilization, the quantity for the treatment group in time 1. What is the utilization for the control group in time 1? So right now, treatment and control, they have not received the treatment has not occurred. It's pre-treatment. These groups should be very close together in how they look because they were randomly selected. Okay? At some point in time, this treatment group gets the treatment. Okay? Then we want to see what is the utilization of the treatment group in time 2 and compare that to the utilization of the controlled group in time 2. Remember, so the control group has not received a treatment, the treatment group has. Okay? So what is the treatment here? That we're giving the price making the price of healthcare go down for this treatment group. For the control group, the price stays the same. It's constant. So I have P bar here. So we've randomly sorted out people. So income is similar for them. Their age is similar, race, gender, that's all similar. The only thing we're changing here is for this top group, we're lowering the price. The bottom group, we're not. So we can try to isolate that effect. All right. And from that, we do two calculations. We do the first difference. The first difference calculation is going to be utilization in time 2 minus utilization in time 1. Okay? For the treatment group. So we would expect, again, it's predicted, if price goes down, quantity should go up. So if quantity goes up, this should be positive. That's our hypothesis. Okay? And we do the first difference for that group, and we do the first difference, I'll do it here, for the control group. Their utilization now minus their utilization, oops, minus C. And our hypothesis is that this should be near 0. If you don't change price, demand theory says you won't change quantity demanded, right? And then the second difference is this. The second difference, or what we call the difference in difference, is the difference of the treatment group minus the difference of the control group, okay? So this is the difference of the treatment group. This is the difference of the control group. And our hypothesis is that the difference in the treatment group minus the difference in the control group is greater than 0. Okay, that means this group is increasing utilization. This group is keeping it the same. That's our demand theory to our hypothesis, okay, to what we would test here. All right. Couple more things. Let me go back to our scientific method here. So demand suggests that when price goes down, quantity goes up. We design research using a randomized control trial to isolate that effect. To see we would expect the treatment group, they see a lower price, higher utilization, whereas a control group would not. Okay, the final thing, this is what chapter 2 is about. There's 2 empirical studies that they do. One is the Oregon Medicaid Experiment. Okay, in the Oregon Medicaid Experiment, let me go back here to my difference in difference graph. In the Oregon Medicaid Experiment, how they do this is the treatment group is the people who win a lottery to get Medicaid expansion. So whereas before they were paying maybe an insurance premium or having to pay out of pocket to go to doctor, the treatment is, at this point, they get into Medicaid. And what Oregon attempted to do is randomly assign this, okay? So they took a group of people who are near qualifying for expansion, and they can only do it so many at a time. They only had a budget to accept some people, not all of them. So rather than saying on a first come, first served basis, they randomly assigned people into the program and not into the program. So it wasn't perfect though. It wasn't a perfect random selection process. And we can talk about that later. So that is a problem with actualizing and operationalizing your research in real life. You don't always get that perfect randomization, random selection. However, they did a darn good job. You know, it's one of the only economic experiments we have for the demand for healthcare. So what the chapter 2 shows you is that most of these hypotheses were shown to be true, okay, or shown to be confirmed, at least in this experiment. So a lot of the people who get into the Medicaid expansion, the price at the point of service goes down, and they utilize more services. They go to the doctor more, etc. So, and they measure it in a lot of different ways. So it's a quite good study. And that's especially compared to what happens to the control group. The other study is the RAND study, which also, you know, has a similar setup and has similar findings. So that's what they're going through here, is that they're going through this process of explaining the theory, setting up their hypotheses, doing these very complex empirical studies, and then finding that a lot of demand theory is verified even in the healthcare context, okay? They also find findings about elastic versus inelastic services, okay? So a lot of this theory is verified by the RAND study and the Oregon Medicaid Experiment. Now, one last piece, and then I'll be done with this lecture, is that how does that, this is the demand for healthcare. How does that translate into better health? Okay, did it lead to better health? So all this test, this quantity, remember quantity is only utilization. But what about health? Okay. Now, in terms of this question, I think these studies were largely not designed to find that out yet. And I haven't looked at follow-ups to these studies recently. But largely, you need to be able to look at someone over the course of a longer time period. And the studies at this time, they were coming out only a year to a year and a half to 2 years after the treatment was enacted. However, there were some indicators that a lot of maybe these long-term physical conditions were not being affected in that short time. So there, I'll put here, they were relatively a short time span. So hard to measure large differences, right? Hard to measure. But there were a few indicators that suggest health was going up. So asking questions related to mental health, people were seeing that their mental health was better. So self-views of mental health seem to be improving. Now, this is reasonable, right? Let's say you live in a world where you don't have insurance. You're going to be worried all the time about your kids getting hurt, about having, having a catastrophic health expenditure. This is real stuff, and it really hurts people in real life. That causes stress. Now imagine if you got selected into this lottery for Medicaid through the Oregon Medicaid Experiment. Now you're covered. That's a lot of stress that's coming off you. So that's the end of the lecture. I'll be posting this up to the video, and I'll stop recording here.